Thank the organizing committee for giving me the chance to speak to neurosurgeons, our colleagues. I hope they will be flexible with us today regarding this issue that actually we have these kind of questions all the time together. So I'm going to be talking about small aneurysms, less than 7 millimeters, unruptured, whether we should treat them or not. And I'm going to be talking on the side of yes, we should. I'm a simple-minded person. I like to start by knowing what I'm doing and why do I do it. So as a start in any disease process, as a physician, as all of us, we like to treat diseases based on a few things. First of all, we try to treat the disease itself, the process, and hopefully we can relieve the symptoms, or we try to relieve the symptoms as well as treating the disease process. The other reason is usually to prevent the disease progression. And the third reason, simplified again, is to prevent any major adverse reactions related to the disease progression itself. So in my opinion, any disease that we can safely treat, and we have the means to do that, should be treated. So in the brain aneurysm area, if we start by do we treat the disease process itself, we're going to all say, yes, we do. But actually, if we look a bit deeper into this answer, we might think, actually, we may not be doing a treatment of the actual disease process itself, because supposedly the disease process is in the wall of the artery that started this aneurysm to form, and we're treating, most of the times at least, we're treating the sac. So sometimes we do not treat the disease process itself. So can we prevent the disease progression? Actually, we do. But actually, maybe sometimes we don't. Because again, if we do not treat the disease process in the wall, we might not be able to prevent any progression. So sometimes we do not do that. So, okay, great. So do we treat the adverse reactions? Do we prevent them from the disease itself or from the treatment? Oh, yes, we do. Oh, actually, maybe we don't. Because sometimes, unfortunately, we do cause, during the treatment process, some adverse reactions ourselves. So it's not looking very good, so far at least. So to answer the questions, people try to do a scientific way of measuring what is the actual disease process, how bad is the disease itself, what's the natural history of the disease, and how can we compare it to the results of the treatment process. So I'm going to talk very briefly today about the two studies that touch on this. The first one is the International Study for Unruptured Intracranial Aneurysms, which was published at The Lancet in July of 2003. They basically randomized about 4,000 patients. About 1,900 or so were treated surgically. About 450 were treated by endovascular coiling. And about 1,900 and so were treated by just observation. In their results, their conclusions came that any aneurysm that is less than 7 millimeters will carry a lower risk of hemorrhage. Now, they did identify that the aneurysm location will also have an implication about the risk of rupture. So now we're talking just the natural history of the disease. And so they decided that the cutoff is about 7 millimeters, and they also concluded that the posterior circulation is more likely to rupture than the anterior circulation. Now, in the Japanese cohort, it's a different type of study. It was not a prospective study. They basically took about 5,700 patients that had close to 6,700 aneurysms. And they basically, what they did, they also discovered, or they tried to assume that the 3 to 4 millimeter size is considered to be a zero risk of rupture. We all know that this is not necessarily true. We do see a lot of patients that do rupture at this small size, but anyway, this is what they decided. And based on that, they tried to kind of speculate what's the risk of, or how much increase, how many folds of increase of risk there is for any increase in the size of this aneurysm. And they found that basically aneurysms that are larger, which is what we already know, are more likely to rupture than the small ones. So also they discovered a couple of things, again, that the aneurysms in the middle cerebral artery posterior and anterior communicating artery are also more likely to rupture. So anatomy had something to do with it, in their opinion. Those that have irregular daughter sacs and so forth, what are the morphological features that we usually look at, are more likely also to rupture. And basically, the history, at least for them, they said that the history of smoking or other risk factors did not, in their study, show any significant increase in the risk of rupture. So basically, what's interesting to me about those two studies is that, first of all, the cohort, the Japanese cohort, they actually did not believe necessarily to randomize fully those patients, because those that they believed already beforehand that they had higher risk of rupture were not randomized, and actually they underwent treatment within 4 to 6 weeks. And that's about 2,000 of those aneurysms, which is a big number. That's 1/3. And now, what I also have the problem that both studies did not look into the other things that we consider as probably the cause of the more likely rupture related to the wall abnormalities itself. And unfortunately, we all know that until now, we do not have any strong ways of examining the wall of the artery or the wall of the aneurysm to see whether these are more likely or more prone to rupture. Now, there are some suggestions about it and so forth. Some people talk at the flow dynamics and so forth, but we don't have a strong evidence yet to rely on. So, also the other problem is that we are basically invasive in our treatment, and as we said, the risk of the complications related to the treatment process itself is also high. So, although those studies have been done and a lot of effort has been done, I don't think that we've touched already in the very strong fundamentals of the treatment decisions. So for the patient, let's say what the patient hears when we tell them that you have an aneurysm that's 7 millimeters or less. We tell them you do have a potentially life-threatening problem. Now, it's not a ticking bomb anymore. We don't necessarily say that term, although during my training, we used to at least consider that. And then your risk of bleeding may be about 1 to 2% per year. So what does that mean, doctor? About every 100, you'll probably have a 2% chance, 2 of them will bleed. Okay, great. But if you do hemorrhage, if you do have a hemorrhage or a rupture, there's about 40 to 50% chance of dying. Oh, okay. Okay, what about the symptoms? I have a headache, doctor. Yeah, I'm not sure that we will help you with the headache. I'm not sure that you're going to get better. Okay, great. But if you do happen to live for another year, your risk of rupture will be even more. Okay. So, and if we treat you, we might cause you the rupture that we're afraid of causing, of you having naturally. Okay, great. So now you make the decision. Okay, thank you very much. Maybe you can kill me now, because you really are not helping him in making the decision. We're putting the burden on the patient to make that decision. So I wish we did have a book that tells us, how to treat aneurysms for dummies, and unfortunately we do not have that. We can sit here and discuss the different options, but we truly do not have a way of saying how much of those patients, who are the patients that will actually end up having a rupture. So in summary, the problem is that the treatment that we are giving the patient is a serious treatment. It has complications, it has risk. So if we have a minimally invasive way or a non-invasive way of treating those patients, if we can safely treat those patients, I think that makes it much easier. So for now, most of the concepts that we are using are starting to change, especially when we talk about, for example, the flow diverters. We're treating the parent artery rather than the sac. So maybe this is going to change by adjusting the way that we perform those procedures, making them easier to do, the antiplatelet regimes and all of that. This might decrease significantly the risk. So I believe if we do improve our endovascular techniques and surgical techniques to become truly safe, if we minimize or try to eliminate the risk of the procedure, then I think we should definitely treat all patients. Thank you very much.